Welcome to our educational program today, staying up to date on the treatment of advanced hormone receptor positive HER2-negative breast cancer. I'm Dr. Harold Burstein, an associate professor of medicine at Harvard Medical School and an institute physician at the Dana-Farber Cancer Institute here in Boston, with a special focus in breast cancer management. Our goal for today is to give an overview of hormone receptor positive HER2-negative breast cancer in the metastatic setting, focusing on some of the newer biological insights that have come forward and some of the newer treatment options that are emerging, specifically targeted therapies and combination endocrine strategies. So, as this audience knows well, the goals of treatment for managing advanced or metastatic breast cancer include prolongation of survival while controlling disease-related symptoms. And we use surrogates, including time to progression in clinical trials and measurement of treatment response, to help us understand the literature. On a day-to-day basis, we're obviously very interested in improving and maintaining quality of life for our patients. That means minimizing side effects of treatment and using treatments that are effective at preventing complications from the cancer itself. We factor in a lot the patient preferences in the management of advanced disease. Most women with ER-positive, HER2-negative metastatic breast cancer will get multiple lines of endocrine therapy, targeted therapy, and then chemotherapy. And so it's very important to be acutely aware of how the patient is doing, both from a tolerability point of view and from a cancer burden point of view as you are making treatment decisions. Well, I'd like to begin by looking back at the Human Genome Sequencing Project Cancer Genome Atlas data to make a point about the heterogeneity of breast cancers. We've learned a lot in the past 5 or 6 years about the extensive somatic mutations that arise in breast cancer, and these can be classified in various ways. What's shown on this slide is the frequency of mutations for so-called luminal A breast cancers, which are typically ER-positive, PR-positive, lower grade and less proliferative, versus luminal B tumors, which are also hormone receptor positive, though they often have lower levels of estrogen or progesterone receptor expression and typically have higher scores of proliferation or higher grade features. And what's interesting is that you can see clusterings of these mutations in different subtypes of ER-positive breast cancer. But what's also interesting is that in contrast to some of the work that's been done, say, in lung cancer or other tumor types where there are more discrete mutations, within the group of ER-positive, HER2-negative breast cancer, there aren't unique mutations that stand out for treatments that we know we have targets for in present. So we do see, for instance, high rates of PIK3CA mutation. Somewhere on the order of 30 to 40% of all cancers that are ER-positive will have such mutations, though at the moment we don't have a targeted therapy that directly goes after that. Now, when you look at the TCGA data, you have to remember that these were done on tumors defined at baseline, typically at the time of diagnosis. And perhaps one of the most interesting biological insights we've had into advanced breast cancer recently has been the realization that resistance to endocrine therapy is often accompanied by mutations arising within the ESR1 gene. So if you look at the TCGA data, actually very few tumors at baseline have mutations in ESR1, or the estrogen receptor 1. But when you start to sequence tumors that have recurred or spread to other organs, including the bone, the lungs, the liver, and so forth, you find that there's a much greater likelihood of a new acquisition of a mutation in the estrogen receptor. And recent estimates put that as high as something on the order of 30 to 40% of all cases of recurrent breast cancer, especially in women who've had adjuvant endocrine therapy. This slide makes the point again that treatment with endocrine therapy, particularly aromatase inhibitors, which is so universal in our management of postmenopausal women, is often associated with a risk of acquisition of these ESR1 mutations. So you don't see this mutation at baseline. You only see it on resequencing of tumors once the cancer has recurred. Now, what we don't know from a biological point of view is whether we are simply selecting out the rare pre-existing mutations that already are present in the primary tumor, and which in the course of time and adjuvant endocrine therapy are then selected for in sort of a Darwinian way, such that when you sequence the tumor at the time of recurrence, you now find these mutations. We don't know whether that's the model or whether truly all the primary cancer cells have no evidence of the mutation and that it's only in the crucible of selection through the use of adjuvant endocrine therapy that you see both the mutation arise and then eventually the outgrowth of that mutation in the presentation of metastatic disease. So either of these models of clonal selection are possible, and again, we don't have really good answers for which one it is. But what we have seen is that this is clearly a contributor to resistance to endocrine therapy. And that's a very important insight because while clinically we've been using hormonal manipulations for nearly 100 years in the management of advanced breast cancer, we've learned very little about the real cellular and molecular basis for resistance to endocrine treatment. What's interesting about these ESR mutations is that they cluster in the ligand binding domain, and they lead to ligand-independent ER activation. That is to say, the estrogen receptor is turned on even in the absence of binding from estrogen. And this contributes to marked resistance to aromatase inhibitors and may also contribute to relative resistance of SERDs such as tamoxifen or fulvestrant. So what we don't know, again, because it's an area of active research, is exactly how prevalent these mutations are, though in patients coming off of aromatase inhibitors, as I said, it looks like something on the order of 30 to 40% of all recurrent or resistant tumors will have these kinds of mutations. So this is a common problem that we've now only recently begun to recognize. So what we are interested in knowing here is how does the presence of an ESR1 mutation play out in terms of clinical management and outcomes? And the data here are from the so-called SOPHIA study, which was a randomized trial for women previously treated with an aromatase inhibitor, comparing fulvestrant or a fulvestrant-based regimen with a pure aromatase inhibitor regimen such as exemestane. And what you can see in these two data sets are the importance of the ESR mutation both in the natural history of the disease and in the particular treatment option. On the left, you have tumors that have an ESR1 mutation, and on the right, you have the wild-type estrogen receptor tumors. And first thing that jumps out is that if you compare left and right, you'll see that the median time to progression on the left is on the order of 3 to 5 months, whereas on the right, it's on the order of about 5 to 8 months. So the presence of the ESR mutation probably hastens the ultimate time to progression. The other thing you notice is that there's an interaction by treatment and ESR mutation type. So on the left, you see the mutated tumors, and there you see better outcomes for the use of the selective estrogen receptor degrader fulvestrant, which was better at improving progression-free survival than the AI. And that fits with our hypothesis that when the ESR is mutated, then the cancer is activated even in the absence of ligand binding, so in the absence of estrogen, whereas a selective estrogen receptor degrader should still work because it physically breaks down the estrogen receptor. On the right, by contrast, where there is wild-type activity of the estrogen receptor, you see that either of these two treatment approaches yields equivalent outcomes. So what are some of the other things we've learned from these sequencing strategies? Well, increasingly there is a lot of interest in sequencing metastatic ER-positive disease and matching them with primary tumor controls. And some recent work by my colleague here at Dana-Farber, Nick Wogley, presented at the San Antonio meeting in 2016, showed that there are other genes that are also newly mutated in comparing primary tumors with metastatic tumors. And these include acquisition of mutations in P53, GATA3, PIK3CA, activating mutations, interestingly, in ERBB2 or HER2. These are not genome amplifications, but they're actual mutations, and some other genes. So I think that these are the kinds of data we're going to be incorporating more and more into our management of ER-positive breast cancer as we become more familiar with and comfortable ordering these kinds of resequencing strategies. And again, the key point is we're going to want to be sequencing the metastatic site and not the primary tumor. Well, let me switch gears here and begin a discussion of the optimal treatment program for ER-positive metastatic breast cancer. Some recent trials have been focusing on whether or not fulvestrant, the selective estrogen receptor degrader, is the optimal first-line treatment. And a couple of these trials we're going to go through in some detail. They include studies that have looked at the combination of an aromatase inhibitor and fulvestrant, or fulvestrant itself versus an aromatase inhibitor. So there have been two studies that have compared adding fulvestrant to AI therapy for de novo metastatic breast cancer. that is ER positive and HER2 negative. The two trials were the so-called FACT trial, F-A-C-T, FACT, or the SWOG 226 trial, which are shown on your slide here. And even though these studies had the exact same treatment design of anastrozole plus or minus fulvestrant, and even though they used the exact same doses, they ended up with somewhat different results. As you can see on the left, there was no measurable improvement in the FACT trial, whereas in the SWOG 226 trial, there was a suggestion of an improvement in progression-free survival, and in fact, some small benefit even in terms of overall survival for the combination. How could we get such discordant results? Well, the likely explanation is probably that the women in the FACT trial had all previously, or were more likely to have previously been treated with adjuvant endocrine therapy, whereas those in the 226 trial were more likely to be de novo metastatic disease without prior endocrine treatment, or to be a long time, measured in many, many years, since adjuvant therapy. And so the way I've taken these to heart is that in a woman who's recently had adjuvant endocrine treatment, I usually just use one endocrine approach at a time. Whereas in a woman who has truly de novo metastatic disease or has had a very long disease-free interval since discontinuing adjuvant endocrine therapy, one is occasionally tempted to add the fulvestrant to the aromatase inhibitor based on the 226 data. The other question is how the drugs would compare head-to-head. And there have been a couple of studies that have come forward, most recently the so-called FALCON trial, which was a study looking at fulvestrant versus anastrozole as first-line therapy for treatment-naive, hormone receptor-positive metastatic breast cancer. And this study was a large randomized phase 3 study that built on the previous results from a study that was called the FIRST trial. The FIRST trial was a smaller randomized phase 2 and had actually shown a major advantage for fulvestrant-based treatment in comparison to anastrozole. And that set the stage for the FALCON trial, which was a larger study of roughly 450 women randomized to either fulvestrant or to the AI treatment. What you can see here actually is that the results look nearly identical. There's perhaps a small numerical advantage for fulvestrant, but most of us have not found these data to be as compelling as we had hoped. And especially given the convenience of very first-line anastrozole-based therapy, which is a pill and the patient does not require an injection, we typically give the single-agent aromatase inhibitor in this type of patient population because it was hard to see that initial use of the fulvestrant by itself was so compelling. Well, the other thing that's really changed in some of the recent trials of ER-positive metastatic disease has become the widespread use of adjuvant therapy. And of course, this needs no background for this audience. But when you look at trials from the 1990s, when women might have had adjuvant tamoxifen and then were receiving treatment with aromatase inhibitors or then fulvestrant, they really look very different from some of the studies in more recent vintage where patients might have had both tamoxifen or an AI or longer durations of therapy. And given that, we're seeing more and more the need to add to endocrine treatments, particularly with targeted therapies. And that's where a lot of our discussion is going to shift because we've already been administering these anti-estrogens like tamoxifen and aromatase inhibitors in the adjuvant setting. So with that, we'll transition to probably the most exciting area of innovation in ER-positive metastatic breast cancer in the clinical space, which has been the emergence of multiple different CDK4/6 inhibitors as important agents in the palliation of this disease. This is a cartoon, a recent publication by Rich Finn at UCLA, who really did a lot of the preclinical work in Dennis Slayman's laboratory to provide a rationale for looking at CDK4/6 inhibitors in the management of ER-positive metastatic breast cancer. Just to remind you of the basics of the cell cycle, you'll recall that cyclins help drive the transition from G1 into S phase, that there are multiple cyclins and that these in turn are regulated by cyclin-dependent kinases. There are multiple cyclin-dependent kinases, and the ones that are the most common target of our current drugs are CDKs 4 and 6. And when they get phosphorylated, they then turn on RB, which in itself is phosphorylated, and then drives the transition of the cell cycle. So what's emerged has been several drugs, two now commercially available, palbociclib and ribociclib, and a third far along in development, abemaciclib, all of which have CDK4/6 inhibition properties and in theory can be very powerful at controlling cell proliferation in these cancers. Here's another example of cartoon just to make the point about the interactions between the CDK4/6 and cyclin D1 in particular, contributing to that G1 and S phase transition. In theory, these drugs should be active in any cell that is still dependent on a functioning RB molecule. One of the selection criteria in preclinical development was the idea that you needed tumors that were RB expressing. Otherwise, if the cell cycle was so dysfunctional, you wouldn't see activity of these drugs. Fortunately, it turns out that the vast majority of ER-positive metastatic breast cancers still have functioning RB and are potential candidates for these drugs. This cartoon shows you the chemical structures for the 3 commercially developed CDK4/6 inhibitors, abemaciclib from Eli Lilly, palbociclib from Pfizer, ribociclib from Novartis. And it makes the point that there are some chemical differences between these, both at the structural level and at the level of inhibiting different cyclin-dependent kinases. So all of them have CDK4 and CDK6 inhibitory properties at the nanomolar level. Interestingly, abemaciclib may have some inhibition as well of CDK9 and perhaps CDK2, more so than these other drugs. Whether that is something that emerges as a clinically important distinction is something that very much remains to be determined. Now, when Rich Finn was working out which cell lines to study for initial clinical trials looking at CDK4/6 inhibition, he and his colleagues at UCLA ran through a whole series of breast cancer cell lines. And the outcomes are shown here in this bar graph, making the point that it was luminal or ER-positive breast cancers, as well as HER2-positive breast cancers, interestingly, that were more likely to show growth inhibition with the drug that became palbociclib, as compared to hormone receptor negative or so-called triple negative breast cancers. And it was this observation that set the stage for most of the clinical trials work, which has focused to date on ER-positive breast cancer. And most of the clinical data I'll be showing you later on are all derived from ER-positive disease. But what's interesting is that these drugs clearly do have activity in HER2-positive breast cancer as well. And now that several are commercially approved, we're beginning to see lots of clinical trials being put forward that are using CDK4/6 inhibitors in HER2-positive breast cancers. And of course, they're beginning to branch out to non-breast tumor types as well. So the commercial development of 2 of the CDK4/6 inhibitors, palbociclib and ribociclib, had nearly identical designs for the registrational clinical trials called Paloma-2 in the case of palbociclib and Mona Lisa-2 in the case of ribociclib. These were both large randomized phase 3 studies for postmenopausal women with ER-positive, HER2-negative metastatic breast cancer who'd had no prior treatment for metastatic disease. And the randomizations were to letrozole alone, the aromatase inhibitor, or letrozole in combination with the CDK4/6 inhibitor. Interestingly, both palbociclib and ribociclib use a 3 weeks on, 1 week off dosing schedule. They do this principally to allow for white blood cell recovery at the end of a 4-week treatment cycle. And the primary endpoint for both of these trials was progression-free survival, of course, as well as safety of the regimen. And it was these studies that led to FDA approval for palbociclib in 2015. Actually, that was based on an accelerated approval from the so-called Paloma-1 study, which had the exact same design but smaller numbers of patients than the Paloma-2 trial. And more recently, in 2017, led to approval for ribociclib. Here are the progression-free survival curves for these important studies, Paloma-2 and Mona Lisa-2. And really, to a first-order analysis, they are almost superimposable. You'll notice that in each group of patients, the control arm, the letrozole alone arm, had a progression-free survival of almost exactly the same, 14.6 months, whereas the addition of the palbociclib to the aromatase inhibitor markedly improved progression-free survival. In the case of Paloma-2, the median PFS was about 25 months, and very similar numbers for the ribociclib group in the Mona Lisa-2 trial. So curves that are almost superimposable and a very clean result in terms of a marked improvement in progression-free survival. And from the point of view of the breast cancer community, I think that what really struck people was this near doubling of the PFS, adding nearly a year's worth of potential benefit to endocrine therapy. If you look at secondary endpoints from these trials, there were very similar trends in terms of slight improvements in objective response rate, or so-called clinical benefit rate, the percentage of patients who go without tumor progression. Remember, in ER-positive breast cancer, it can be difficult to gauge response sometimes because so many of these patients have non-measurable disease, either skin lesions, bone lesions, or pleural effusions and things like that that do not lend themselves to formal RECIST criteria measurement. But clearly some impact on response and stabilization of disease. And the final thing that emerged from these two sets of trials were very similar toxicity profiles. So many of you have had experience with these drugs at this point, and you will know that the major toxicity is neutropenia. This is usually a reversible neutropenia and is rather infrequently associated with febrile neutropenia, but it's the reason why we have to monitor white blood count at the 2-week and 4-week landmarks as one begins therapy and every 4 weeks thereafter. And it's the most common reason in our practice why we have to modify the dose. Dose modification is typically to simply reduce the dose, though occasionally patients also require schedule modification such that instead of 3 weeks on, 1 week off, they end up with 2 weeks on, 1 week off, or things like that. Other common side effects of these drugs include minor degrees of fatigue. You also can see some hair thinning. Actually, the patients see a lot more hair thinning with these drugs than they do with the aromatase inhibitors by themselves. Occasionally one sees skin rashes, anemia, lower GI side effects, minor degrees of diarrhea are also reasonably common. And if you compare across the two trials, the side effect profile for ribociclib and palbociclib are almost identical. It is worth knowing, however, that based on rare events in the Mona Lisa trial, the FDA approval for ribociclib does come with the additional warning that you need to monitor QTc interval with EKGs at baseline and serially, and liver function test monitoring as well when using ribociclib. Now, those were the first-line data. There have been similar studies designed for second-line treatment of CDK4/6 inhibitors built around fulvestrant. The one study we have in that space right now is the so-called Paloma-3 study, which was a randomized trial of patients who'd previously had endocrine therapy either within a year of adjuvant treatment or had had progression on first-line treatment, and were randomized to fulvestrant as second-line therapy, or fulvestrant in combination with palbociclib. And in this report, which was also published in the New England Journal of Medicine a little over a year ago, you again saw a marked improvement in progression-free survival with the use of palbociclib, improving PFS from around 4 months to 9 months. And this again led to a FDA approval for use of palbociclib in second-line therapy, if you hadn't already had it, of course, in first-line therapy. So we are expecting more data on fulvestrant-based CDK4/6 inhibitor regimens at ASCO 2017. It's widely expected that there will be a report on fulvestrant plus or minus abemaciclib, and the company press release states that that's a positive trial. So we're now going to be in a situation where we have a couple of randomized trials in the first line and a couple of randomized trials in the second line, where adding CDK4/6 inhibition clearly improves longer-term outcomes. Well, let me talk a little bit about trying to link the results. As we mentioned at the outset, we're very interested in these ESR1 mutations and how they affect outcome. This is just a slide to remind me that there's a reasonably high prevalence of ESR mutations in women who've progressed on AI therapy. How does that impact the outcome for treatment with CDK4/6 inhibition? And interestingly, it didn't really. So they looked at this very carefully as part of the Paloma-3 trial, which was that study of fulvestrant plus or minus palbociclib. And interestingly, using, again, a fulvestrant-based regimen, so a SERD, as opposed to an aromatase inhibitor, the presence or absence of the mutation here did not really affect outcome with either the control treatment, the fulvestrant alone, or with the combination of the fulvestrant with the palbociclib. So in women who have an ESR1 mutation, fulvestrant, again, is your treatment of choice, and it still looks like adding the CDK4/6 inhibitor is a powerful addition. So there's more data yet to come here. We are looking forward to results from the so-called Mona Lisa 3 trial, which will be the ribociclib-based study of fulvestrant plus or minus ribociclib. And as I mentioned at ASCO, we're anticipating data for an abemaciclib trial. So Where else are we in this literature? So abemaciclib is the third drug. To date, we do not have outcomes for randomized trials with it, though again, there's a company press release that this is going to be a positive study at ASCO. What they have reported has been the so-called Monarch 1 trial, which was a study of abemaciclib, the third CDK4/6 inhibitor, as a single agent to look for toxicity and treatment response. And the hope was that they could find a response rate of approximately 15 to 20% in this trial. Now, this study looked at women who had had more extensive prior therapy. If you look at the table here, you'll see that the majority of these women had had multiple lines of endocrine treatment, and in fact, at least 1 or 2 lines of prior chemotherapy was required to go on to the Monarch trial. So a much more heavily pretreated patient population. And what we see here are the so-called waterfall plots for response. The overall response rate was around 20%. All of that is partial response, which is, of course, typical for ER-positive metastatic breast cancer. And it's a dangerous game to compare across different clinical trials, but there has been the suggestion that perhaps abemaciclib has more single-agent activity than either palbociclib or ribociclib, though that as yet has not been proven. Now, the dosing for abemaciclib is a little bit different, as is the side effect profile, and that's important to know. So abemaciclib is dosed at a fixed dose of 200 milligrams a day, and it's given continuously. So you see less neutropenia with this drug, which is what enables the daily dose of continuously without that 1-week interruption that ribociclib and palbociclib demand. But you do see more in the way of lower GI toxicity, and particularly diarrhea, as a consequence of the abemaciclib than one sees with the palbo or ribo. The other point to know is that because of a chemical artifact in the assay, creatinine levels appear to go up when you give people abemaciclib. This is very confusing to clinicians who are used to seeing like a Chem 20 panel, and all of a sudden there's this jump in the creatinine. But this is an artifact. It doesn't actually reflect true impingement of renal function. It just has to do with how the assay picks up the drug and the creatinine. So again, what we're waiting for in terms of data for abemaciclib would be their randomized trials, so-called Monarch 2, again, which is fulvestrant plus minus abemaciclib, expected at ASCO in June in Chicago. Here's the schema for that trial. It has reported, as I said in the financial press, that it met its primary endpoint, again, of improving progression-free survival. And they, too, are doing a study of first-line therapy, looking at an aromatase inhibitor given with or without abemaciclib. So it's a very unusual situation in the clinical development of a drug for breast cancer, and really for almost any tumor, where within the span of about 2 or 3 years, we're going to have multiple data sets from multiple clinical trials with very similar results, one anticipates, looking at use of these drugs as either first-line or as second-line treatment in combination with endocrine therapy. So the slide here highlights some of the key registrational benchmarks and timeframes for approval of these drugs. Let me just talk briefly about how we're actually using these drugs in clinical practice. At the moment, palbociclib and ribociclib are the 2 commercial options. We are often using these in first-line therapy for patients who are getting an aromatase inhibitor, which is our typical go-to as a first-line drug. Usually, the addition of the CDK4/6 inhibitor has only a modest impact on the general quality of life for the patient. There clearly is more fatigue. You have to monitor the blood counts. That sometimes takes a couple of cycles to actually tweak the right way. The outcomes in terms of lower GI side effects seem to be pretty manageable. It is important to remind patients that they need to discontinue the drug for that last week so that the white blood count needs to recover. Overall, we see very few in the way of infectious complications from these regimens, even though you do see this neutropenia because of the rapid rebound of the neutropenia once you stop the blood counts. In patients who've recently progressed on an AI or progressed on an AI, or for whatever reason aren't candidates for an AI, perhaps because of an ESR mutation, we are using fulvestrant. And in that situation, we are also piggybacking on the CDK4/6 inhibitors, and again, using a very similar schedule of the monthly fulvestrant and the 3 weeks on, 1 week off with the CDK4/6 inhibitor. Now, one of the interesting questions that's already begun to arise is, should you continue CDK4/6 inhibition beyond progression? At the moment, we actually have zero clinical data to suggest that ongoing CDK4/6 inhibition beyond progression is of clinical value. And my colleague here at Dana-Farber, Erica Mayer, has been developing an important trial called the PACE, P-A-C-E trial, to specifically look at that question, taking patients who've progressed on CDK4/6 inhibitor and are then randomized to next-line therapy with or without the CDK4/6 inhibition, specifically to ask that question. At the moment, we do not encourage this clinical practice. There really aren't data that additional therapy is valuable, though I will say there have been some intriguing preclinical observation that have raised the question that perhaps by ongoing CDK4/6 inhibition, you may again potentiate growth inhibition. So we're looking forward to seeing that trial rolled out. Well, I want to talk about other targeted therapies as well, and now we're going to switch gears and talk about mTOR inhibitors, which are commercially available for use in combination with endocrine therapy. As you know, there is a substantial degree of growth factor pathway crosstalk between HER2 and EGFR and ER signaling pathways. Many of these funnel down through the PI3 kinase AKT mTOR pathway, which affects gene expression in a similar fashion to estrogen receptor signaling. And so that had created the rationale for the combination of using everolimus, the mTOR inhibitor, with endocrine therapy in ER-positive metastatic breast cancer. And the data we have for that led to FDA approval were from the so-called BOLERO-2 trial, a randomized study of patients with ER-positive HER2-negative disease previously treated with an aromatase inhibitor and randomized to exemestane alone or exemestane in combination with everolimus. As you can see from this New England Journal publication by Jose Baselga a few years ago, an improvement to 7 months PFS from around 3 months PFS with the addition of everolimus to exemestane. Now, the major side effect of everolimus is stomatitis. That's been the biggest problem in routine management. At the 10 milligram dose, about 30% of patients will get reasonably substantial stomatitis. There's also risks for hyperglycemia, for somewhat idiosyncratic pneumonitis, and it does enhance fatigue. Overall, I got to say my impression is that everolimus is a slightly more toxic drug than some of the CDK4/6 inhibitors, and so we typically go with the CDK4/6 inhibitors first. We don't really have a lot of data for the use of everolimus after CDK4/6 inhibition, though there are studies that are now looking at that. And perhaps more interestingly, there are also studies looking at the combination now of everolimus with CDK4/6 inhibition to see if multiple targeted pathway inhibition can be a clinically viable approach. Those data remain to be presented at our important meetings. There are other trials that have looked at everolimus. This is the schema and outcomes for the so-called TAMRAD trial, just making the point that whether you used an aromatase inhibitor or tamoxifen, you saw a clinical benefit for everolimus. And the final set of data we have in this slide deck is from the ECOG trial 0102 that recently was an analysis of fulvestrant given with or without everolimus. Remember, the BOLERO study was with an aromatase inhibitor, and it showed a very similar trend, which was that if you added everolimus to fulvestrant, you saw again an improvement in PFS from around 5 months to around 10 months with a very similar safety profile. So based on the BOLERO data, everolimus is approved. As we've noted, there are concerns about stomatitis and rash and diarrhea. I know that in the community practice, a lot of people give this drug at the 5 milligram dose, which is its FDA dose for other indications. It's not actually the breast cancer indication dose, and we don't really know a lot about the clinical benefit for use of the drug here. This is seemingly not a generalizable principle. There was a different mTOR inhibitor called temsirolimus, which was also studied in years past, and temsirolimus did not seem to improve progression-free survival in the so-called Horizon study published by Antonio Wolf several years ago now. So where are we in thinking about other targeted pathways? Well, for about 10 or 15 years now, there's been a lot of interest in the PI3 kinase inhibitors. As the cartoons a couple of slides ago noted, the PI3 kinase pathway feeds into several of the growth factor pathways that are thought to be important in ER-positive breast cancer. And as we said at the outset, it's a very commonly mutated gene in ER-positive metastatic breast cancer. So conceptually, there's been a lot of interest in using PI3 kinase inhibitors in ER-positive disease. The dilemma has been that to date, with so-called pan-PI3 kinase inhibitors, there's been less proof of activity than one might have anticipated. The drug called pictolisib did not markedly improve on outcomes compared to fulvestrant alone. Beparlisib was studied in the so-called BEL-2 and BEL-3 trials, where it did modestly add to outcomes, particularly in the subset of women whose tumors had known PI3 kinase mutations. But the toxicity profile of the drug was such that it's really not adequate for clinical use. There are significant neuropsychiatric side effects of the drug. So what remains to be really studied, and there are drug trials now underway here, is the use of, for instance, alpha-selective PI3 kinase inhibitors in tumors selected to have a PI3 kinase alpha mutation. And I think that that's going to be the best case scenario for PI3 kinase inhibitors moving forward, but we don't have data from those trials as yet. So let's try in the last few minutes to sort of put all this together, thinking about the optimal use of mTOR inhibitors and CDK4/6 inhibitors and our existing ER-targeted agents in the management of advanced disease. Again, the goal here is to control the cancer, to maintain and improve quality of life. And really, the unspoken goal is to delay the initiation of chemotherapy for as long as possible. Now, most of these patients will have bone metastases, so it's also very common that these women are getting bone-modifying therapy, either with denosumab or zoledronic acid at the same time. So it's not like these patients are not coming into the clinic and getting parenteral medications. At the same time, there is a great appeal to avoiding the relentlessness of the chemo infusion suite, which is something that often arises once you pull that chemotherapy trigger. So here's some guidelines that have emerged in the past year or so from NCCN and from ASCO, looking at optimal treatment strategies for recurrent ER-positive HER2-negative disease. I sit on both of these panels, and I've had the privilege of helping to develop some of these guidelines. This is the NCCN guideline slide, and the key point here that it makes is that if you have a patient who is premenopausal with ER-positive metastatic disease, really the first thing you're going to do is render that patient postmenopausal, either with surgical oophorectomy or with medical oophorectomy using GnRH agonist therapy. Essentially, all the modern literature looking at aromatase inhibitors, fulvestrant, CDK4/6 inhibition, mTOR inhibition, any other therapy you wish to mention, is only studied in postmenopausal patients. So as Dan Hayes has quipped, there's really no such thing as a, quote, premenopausal woman, unquote, who has ER-positive metastatic cancer, because the first thing you're going to do is put that patient into medical menopause. Once that's done, you have a variety of choices, including aromatase inhibitors as single therapy, aromatase inhibitors in combination with CDK4/6 inhibition. Occasionally, patients progress on the AIs, and so you're going right away to fulvestrant-based treatments as first-line regimens. And for some women who've had multiple endocrine treatments and still have reasonably indolent cancer, there are a few tricks to remember. One is to think about progestational agents such as megestrol acetate or fluoxymesterone, drugs that go back to the 1960s and 70s and 80s, but which clearly had activity in tamoxifen-pretreated patients. And even estradiol itself. Matt Ellis, now at Baylor, had reported that you can see clinical activity in indolent ER-positive breast cancer with that treatment approach. Next up then is a summary of our ASCO guidelines that Hope Rugo from UCSF and I had the privilege of co-chairing. Again, we focused on sequential hormonal therapy being the standard. Again, the threshold here is rather low. Tumors that express any degree of estrogen receptor can, in theory, be sensitive to hormonal manipulations, though when estrogen receptor expression becomes vanishingly low, then you're less likely to see substantial clinical response. And in the guideline grids, which are shown here, probably in too much granular detail, you see outcomes for patients who are treatment naive, no prior adjuvant endocrine therapy, or patients who've had either tamoxifen or AI treatment. And what you get at pretty quickly is a situation where you're looking at either AIs given with or without CDK4/6 inhibitors. In some instances, you can double down on the AIs plus fulvestrant, as we mentioned earlier in the program, or going directly to a fulvestrant, again, with or without CDK4/6 inhibition. In second line, you're really talking about whatever the patient hasn't had already. So if they did not get fulvestrant, if they have not as yet been exposed to a CDK4/6 inhibitor, then you're offering them that. What we'd really like to know, but don't have data to drive the decision-making for, is are there some patients who could be spared the toxicity and the cost of a CDK4/6 inhibitor either upfront or in sequential therapy. And undoubtedly, there must be women who have rather minimal disease burdens, who probably have a very long disease-free interval, and for whom one could very safely delay the CDK4/6 inhibitor. In fact, we do that occasionally in clinic, especially for women who are worried about the side effect profile of these agents, who have minimal disease burden, who've had a long disease-free interval. I think it's quite reasonable still to offer, say, just an aromatase inhibitor to that patient. But to date, when they've actually looked in the various clinical subsets, it's been almost impossible to find a clinically defined or even a cellular or molecularly defined group of women who don't seem to benefit from the addition of the CDK4/6 inhibitors in terms of longer period of tumor control. So on a case-by-case basis, we occasionally spare the patient some of the CDK4/6 inhibitor therapy, anticipating that we will use it down the road. But for most women, we're more inclined to use it up front in either first line, whether that's with an AI or with fulvestrant. And as I mentioned, there really aren't data for continuing CDK4/6 inhibition beyond progression. Now, because ER-positive metastatic breast cancer has a long natural history, there is a group of women who have had AIs and have even had fulvestrant a long time ago. They might have started years ago with those treatments, back before CDK4/6 inhibitors were available. And in those patients, we've been anecdotally trying CDK4/6 inhibitors like palbociclib, and of course, more recently, ribociclib is now available. And you will see occasional evidence for clinical benefit. I've had some patients with reintroduction of hormone therapy in combination with the CDK4/6 inhibitors who've actually had nice marker responses or even radiologic responses, though these patients don't tend to fit the registrational criteria. And the other caveat here is that because most of these patients have actually had more chemotherapy, I think you do see somewhat more in the way of bone marrow side effects, lower blood counts, more anemia, even some thrombocytopenia with palbociclib when you end up using it in these more heavily pretreated patients. Just something to be aware of. In patients whose tumors are resistant to AIs, fulvestrant, and typically CDK4/6 inhibitors, then we're looking at adding everolimus or some of the older endocrine manipulations that we talked about. So again, the art here of managing ER-positive metastatic disease is to look at the patient you're with, think about what their symptom profile is from their cancer, their general performance status, their baseline laboratory studies, the likelihood that they're going to have rapid tumor progression, and then make a reasonable decision about which product to use based on what they've had in the adjuvant setting, your estimate as to their general disease burden and likelihood of needing more versus less in the way of treatment right now, and then making some choices. Because patients can be on these drugs for long periods of time, you spend a lot of time monitoring them and adjusting the regimen based on toxicities. We've talked a little bit about dose modification and schedule modification issues. It's important to ask if patients are adherent with the medications and using them as intended, and to inquire about some of the more atypical side effects, in particular things like consequences of neutropenia or diarrhea with the CDK4/6 inhibitors, things like hair thinning with the CDK4/6 inhibitors, things like stomatitis or pneumonitis or hyperglycemia with the mTOR inhibitors as well. There still are side effects of endocrine treatment itself. These include bone pain and arthralgias. It can be tricky in ER-positive metastatic breast cancer to sort out whether patients are having tumor progression causing bone pain or whether they're having bone pain from drugs like AIs or even bisphosphonates, which can contribute to some bone discomfort. And so, getting to know your patients and really paying careful attention to some of these more common but subtler side effects is a very important task. So before concluding our program with a couple of quick case discussions, let me just offer a few key takeaways for ER-positive metastatic breast cancer that I don't think we've really necessarily covered in the more granular discussion of some of these newer drugs. This is a disease which has a long natural history, and the goal here is to use hormone and targeted manipulations really for as long as possible. Some patients may need chemotherapy along the way to obtain a clinical response and prevent worsening of symptoms. And if you do use chemotherapy, you always want to remember to try and go back and reintroduce endocrine treatment if at all possible. In addition, we try to biopsy all of our cases of newly diagnosed metastatic breast cancer, including ER-positive disease, and we do that nowadays for several reasons. First, we want to confirm that it's cancer and not some other tumor type or a benign condition, which especially in pulmonary nodules or bone lesions can occasionally be a fake out. The second is that there is this increasing interest in doing genomic sequencing on these tumors, and it's clear that the tumor at recurrence is going to look different from the tumor at baseline. So getting a biopsy at the time of recurrence or progression is going to be a very important goal. Fortunately, most women with ER-positive disease will not present in visceral crisis and so do not need urgent chemotherapy. And so for most women, the initial treatment should be endocrine therapy, either by itself or in combination with one of these targeted agents we've been talking about. A typical scenario for me is to offer first-line patients either an aromatase inhibitor or fulvestrant based on what they've had in the adjuvant setting, and that's very often in combination with CDK4/6 inhibitors, particularly palbociclib, because it's been on the market for longer at this point. And patients are doing quite well. They do require, obviously, monitoring. ER-positive metastatic breast cancer can be difficult to follow. Bone lesions, pleural effusions, and other non-measurable things like skin lesions or abdominal carcinomatosis can be notoriously difficult to monitor. And so you really have to ask the patient how they're doing. We occasionally follow tumor markers in these patients, and there the caveat is that you got to educate patients so that they're not waiting every day or every month for their tumor marker results, because small changes in tumor markers, especially in the short term, can turn out to be a lot less important than people often imagine. And then hopefully with minor dose adjustments, you can get patients to tolerate these targeted therapies in combination with endocrine treatment and prolong really their quality of life and their obviously period of tumor control while doing very handsomely. So let's now switch to the final portion of our talk and look at a couple of cases that might be reasonably typical for you and talk about where we might go with management. So case one is a 66-year-old woman who presented with right upper quadrant discomfort. She previously had had a 2.5 centimeter ER-positive HER2-negative breast cancer diagnosed 7 years ago, for which she had had lumpectomy, radiation therapy, and aromatase inhibitor treatment with anastrozole for 5 years. She had stopped her adjuvant therapy about 2 years ago. A workup for her right upper quadrant discomfort disclosed 3 hepatic lesions, the largest of which is 9 millimeters, and was biopsied, and it confirmed hormone receptor positive, HER2-negative metastatic breast cancer. So what other testing or imaging studies do you need to do, and what factors might you consider when recommending treatment for this patient? What do you want to know about her cardiac, hepatic, or renal function, and her baseline status? So let's assume that she's in reasonably good health. She tolerated the aromatase inhibitor reasonably well in the past, that her serum chemistry profile is essentially normal, and aside from the mild abdominal discomfort, she's not really having any marked symptoms from her cancer. Well, you'd want to get a bone scan, obviously, or PET-CT scan to look for bone metastases. That's very important for understanding whether or not to start bone-modifying therapy. These days, we would try and sequence this patient's tumor. We don't know that that's going to immediately change her clinical outcomes, but if we knew that she had an ESR1 mutation, it probably would steer us towards fulvestrant as opposed to reinitiation of the aromatase inhibitor treatment. So here are your treatment choices. Would you start everolimus and exemestane, palbociclib with letrozole, palbociclib with fulvestrant, ribociclib with letrozole? Consider a clinical trial with abemaciclib or with ribociclib and fulvestrant, or are you unsure? Well, I think the right answer here is you probably should be a little unsure. There are a lot of different directions one could go in this case. Typically, we are offering CDK4/6 inhibition in patients like this. I think if you had a clinical trial, it would be great to refer the patient for a study looking at those combinations. Outside of a clinical trial, and assuming that she had relatively modest symptoms, we would probably resume the AI with the patient having had a 2-year disease-free interval and combine that with the CDK4/6 inhibitor. Typically use palbociclib here, but you could use ribociclib, which was just approved. And we typically reserve the everolimus for later line treatment. I don't think it would be wrong to give fulvestrant here, particularly, as I said, if there was an ESR1 mutation. So she got palbociclib and letrozole and did quite handsomely with it for just shy of a year, a repeat set of staging scans done, and had now developed bone lesions as well as a pulmonary nodule. She remained minimally symptomatic. And so the question that's posed here is, what would you do next? Should you stay with the current regimen or switch therapy? So the interesting thing about ER-positive breast cancer is that there are many situations where we do continue treatment beyond progression. I'll oftentimes have a patient who's been on, say, an AI or AI plus CDK4/6 inhibitor, and will have very subtle progression in the bone or in the lymph node. And where you sense that they still might be getting some clinical benefit, you might just leave them on that regimen and just monitor this, especially if they were tolerating the regimen and had few symptoms. However, in a case like this, where we had new bone lesions and a new pulmonary nodule, my inclination would probably be to switch therapy. Since they'd already had the CDK4/6 inhibitor, I would not continue that. We would typically just offer fulvestrant in a situation like this, though I suppose one could also pick aromatase inhibitor treatment with everolimus if you were so inclined. And finally, then, we will look at our second case, case 2, which is a woman who presented with de novo stage 4 ER-positive HER2-negative breast cancer in late 2015 when she had an imaging studies done for back discomfort and was noted to have bone metastases in the lumbar spine. She was put on letrozole therapy for 13 months and had some degree of fatigue emerge after that year of therapy. And at that juncture, a workup disclosed new metastatic disease in the liver. She began fulvestrant therapy, which continued for 9 months, and then began to have progressive disease again in the liver, now resistant to presumably both letrozole and to fulvestrant. Did you introduce everolimus with the aromatase inhibitor? Would you add palbociclib to the fulvestrant, or add palbociclib and reintroduce the letrozole? Or I guess the real question is, would you add chemotherapy in a situation like this? But that's not one of the options that's listed here. So in this instance, the patient chose everolimus plus exemestane. We've talked about that as a regimen, and you certainly can see activity here with it. I think other choices could have included just adding the CDK4/6 inhibitor to the fulvestrant that she'd already been on. We've certainly done that in some cases and seen some evidence of clinical control. Whether that's the best way to use those drugs really is not known. And now with her second progression in the liver, I think the real looming question is, when would she need chemotherapy? Hopefully she'll have a good outcome with the targeted treatment still, and we can defer chemotherapy for yet another day. Well, thank you for joining us today as we've been discussing some of the newer biological insights and treatment options for ER-positive metastatic breast cancer. This is a disease where patients can often do well for a long time and will have multiple treatment options and multiple lines of therapy. And that makes it incumbent on the clinical team to really pay a lot of attention to the symptoms the patient's having, modifying treatments to minimize those symptoms, and following the cancer burden closely, even though these can be patients where the cancer burden is sometimes difficult to gauge. And it often takes waiting a while to see what both the treatment effect is going to be and whether the cancer is truly progressing. What's also been fascinating to me over the past couple of years is you took a disease that we thought we knew everything about, ER-positive metastatic breast cancer. We had aromatase inhibitors, we had SERDs, we had older drugs like progestational agents and even estradiol itself and tamoxifen. But that seemed like the armamentarium. And what we've learned in the past few years has really been that these targeted drugs can successfully interact with the ER signaling pathway, dramatically improve periods of tumor control, give the patient more options with relatively manageable side effects. And we're also learning that it's very important to think about the biology of the tumor. I think this ESR mutation story is going to more and more affect the kinds of treatments people are getting, in the sense that they'll be switching away from AIs sooner if there's an identifiable mutation. And it's been fantastic to see all this come forward for a disease that we thought we already knew the answers to. So with that, I thank you very much for joining us for today's program. I look forward to talking to you again soon.